introduction. It's my pleasure to speak with you all today about one of my favorite topics, which is how we're making progress in peripheral T-cell lymphomas. These lymphomas are quite rare. So, when you talk about patients who have lymphoma across the United States, there are about 16,000 cases per year. The rate of that is rising with our aging population. But the term lymphoma really reflects over 100 different diseases in the current classification systems. So how do we break them apart? So the way I teach our fellows and our residents is that the lymphomas arise from a halt in the normal maturation process or the halt of normal ontogeny. And so these, one diagram you see here is in the B-cell ontogeny tree, where you see the development of stem cells to more mature cells. And the same thing happens with T cells. As cells mature and move out of the stem cell niche, they gain and lose certain properties or factors or cell differentiation factors on their cell surface. And when patients develop lymphoma, that means that that particular cell stops learning how to mature and move further in stage. And then how we determine which type of lymphoma patients have is based on what markers are present on those cells, suggesting what the cell of origin. How do we make a diagnosis of lymphoma? We do this always with a biopsy. So this biopsy can be done from taking out a full lymph node or taking a piece of a lymph node. The bona fide method or the gold standard has always been to do an excisional biopsy, but core needle biopsies are increasingly common to make a diagnosis. So most often, at least in the United States, we get PET imaging or some sort of imaging to look for the most suspicious node and then try to biopsy the node that we're most concerned about. This can be done using a core needle biopsy or an excisional biopsy, and in certain types of lymphomas, this can even be done in the blood and the bone marrow. So I think in the end, I see a lot of patients with T-cell lymphoma who unfortunately don't have the best outcomes, and that invigorates me to say, well, we got to do better than we're doing now. And whether that means making better treatments for patients with relapse disease, bridging them to allotransplant, or making more tolerable treatments for patients who can't get an allotransplant. That can hopefully lead to improving strategies in the frontline setting, and then hopefully predicting from the beginning who's more likely to respond and who's less likely to respond using imaging techniques or minimal residual disease techniques or gene expression profiling techniques that hopefully will ultimately gear and personalize treatment for patients based on their histology and based on their biology. And ultimately, we need to translate this to the community and improve access to care, because not everybody is fortunate to live near a large academic medical center and have access to all of this information. So for rare diseases, the dissemination of this information is critical. And we hope that one day, we're not going to treat all these diseases as one lump sum, but we'll really treat them based on the category and the biology of these diseases, which can lead to better treatments for them in the frontline setting and the relapse setting, and ultimately result in better survival curves and better outcomes for our patients.